Respected physicians and today's audience, good morning. আজকে আমাদের ইসিজি সেশনের সপ্তম পর্ব এবং আজকের পর্ব খুবই ইম্পর্টেন্ট এবং বেসিক্যালি আমি রফিক স্যারকে আমাদের আজকের স্পিকার রফিক স্যারকে পার্সোনালি রিকোয়েস্ট করেছিলাম ইমার্জেন্সি ইসিজি এর ব্যাপারে। তো আমাদের আজকের টপিক হচ্ছে ইসিজি ফাইন্ডিংস নিডিং ইমার্জেন্সি কেয়ার। যথারীতি আমাদের মাঝে আজকে উপস্থিত আছেন আন্তর্জাতিক খ্যাতিসম্পন্ন ইলেকট্রোফিজিওলজিস্ট ডক্টর রফিক আহমেদ। ডক্টর রফিক আহমেদ স্যার কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডিস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, এমডি, ইউএসএ। আমি আর কথা না বাড়াই, আমরা সরাসরি আজকের প্রেজেন্টেশনের জন্য আমাদের সর্বজন শ্রদ্ধেয় ডক্টর রফিক আহমেদ স্যারকে আহ্বান জানাচ্ছি।
Good morning, Assalamu alaikum. So today we're going to talk about ECG changes which need emergency care. I cannot touch all of them, but I'm going to touch something. But before that, I'll show you a picture. This is my new hobby. I have started, I always like catching fish, but this is an interesting fish called walleye. I recently caught this in a river here. So what are the conditions that ECG change that requires emergency care? One is bradycardia, of course, symptomatic sinus bradycardia. If somebody develops asystole or pauses, or somebody develops symptomatic 2-to-1 heart block or complete heart block. Tachycardia, atrial flutter fibrillation with rapid ventricular response, especially if they're hemodynamically unstable. Supraventricular tachycardia, ventricular tachycardia, and acute myocardial infarction. Today I'm going to touch on the bradycardia and acute myocardial infarction, because otherwise it will become too much of a topic to discuss in one day. Do you want me to keep it a lecture format or do some interactive also?
স্যার বোথ, বাট লেকচার ফর্মেও স্যার কিছুটা থাকলে ভালো হবে, কারণ এটাতে স্যার একটু এও থাকলো বোথ থাকলো স্যার। থ্যাংক ইউ স্যার।
Sure. Okay. So this is an example of a patient who was admitted to hospital with history of syncope. And during telemetry monitor, you can see that patient was in atrial fibrillation with rapid ventricular response, and then converts with a long pause. This is one of the pauses, and then there is a second pause. This is the same pause, I'm just extended it. So you can see it's about 6 seconds, 8-second pause, and then there is a junctional beat, and then sinus rhythm comes back. So this is basically somebody that really needs to be looked at emergently. Either the patient will need a temporary pacemaker placed or a permanent pacemaker. Most of the time when we have patients like this here, we do the pacemaker same day. Of course, Bangladesh, the context is different. So probably a patient like this will need a temporary pacemaker followed by permanent pacemaker. The reason we like to do permanent pacemaker same day is once we put the temporary pacemaker, the risk of infection goes up. And the longer you keep the temporary pacemaker, the more will be the risk of infection. So we try not to put temporary pacemaker if we can do this. So this is another patient. Again, patient presented with history of syncope. His ejection fraction is a female patient. Her ejection rate 25 to 30%, and history of atrial fibrillation. And you can see that this is actually a rhythm with heart rate around 61 beats per minute, but there is no P wave before the Qrs complexes. I'm going to follow lead V1 here. You can see there is a right bundle morphology Qrs, no P wave. So this must have been a junctional rhythm. And this is at 1726. And then a little while later, same day, this is July 28, and same day, patient has now back in sinus rhythm with right bundle morphology. If you look at next day, patient develops junctional rhythm with left bundle morphology. Now, why this is important? And of course, the patient's old ECG, if I go back a year earlier, had left bundle morphology. So a patient like this, who presents with a right bundle morphology with history of syncope, baseline has left bundle branch block. What it means, and also the other thing that we have here, that you can see that there is marked first degree block. So this patient has significant conduction system disease with history of syncope. And when there is first degree AV block, that means there is conduction, AV node conduction is abnormal or his bundle. Patient has right bundle, and prior to that had left bundle. That means both right bundle and left bundle, both of them are diseased. So this is one patient that I cannot just send this patient home. If I have a patient in the office who chronically had left bundle branch block, has history of syncope, and today I find Ecg right bundle, I'm going to admit this patient to hospital same day. And then I decide on an implantation of permanent pacemaker. This patient ended up needing a permanent pacemaker. This is another patient that was, let me see if I have the previous ECG. No. Admitted to hospital. This ECG was in the emergency room and comes with history of syncope. And as you can see, the heart rate is 29. Not only that, there may be a P wave before the QRS, very close, but these are different morphologies, and very, like this one is negative, this one is positive. So significant bradycardia, most likely an atrial rhythm with marked bradycardia. And also the patient, other finding that patient has right bundle branch block and left anterofascicular block. And of course the T wave changes, but those are different. So this patient clearly needs somebody with history of syncope presence with this ECG needs to be admitted to hospital. Now, one of the things that we always look at is if this patient is on any medicine. If the patient is on medication, then medication like beta blocker, calcium channel blocker, that is something that we're going to hold first. Now the question is, should I put a temporary pacemaker in? Initially, we'll try to avoid it, but this heart rate 29 will make everybody nervous. We can use medicines to improve the heart rate. Atropine, people always ask me about atropine. The problem with atropine is a very short-acting medication, and we cannot just keep giving it. So if we have to give some medicine, we can give isoprenaline or similar thing, dopamine, we can give dobutamine to increase the heart rate. And dobutamine, only problem with dobutamine, it also increases contract. So that can increase the heart rate, or if need be, we'll put a temporary pacemaker in. And the reason I will put a temporary in this patient, that if this patient is on medication, let's say patient is on metoprolol 100 milligrams BID, at the same time is on calcium channel blocker, I would like to have these medicines wash out before making a decision whether patient needs the permanent pacemaker or not. On the other hand, if the patient is not on any of those medications and there is no other cause for this bradycardia, we will put a permanent pacemaker in. But nevertheless, this patient, of course, will be admitted to hospital. So this is another patient, came to the emergency room with syncope, but if you look at the first ECG, sinus bradycardia with heart rate of 46 beats per minute, PR interval 240 milliseconds, QRS duration is fairly normal QRS duration. Nothing remarkable. I mean, this patient was admitted to hospital, and you can see that this is 5 o'clock in the morning, and in the hospital, while in the telemetry floor, developed marked bradycardia. This is junctional bradycardia. How do you know this is junctional bradycardia? You can see, I'm going to come back to this one. If you look at lead V1, there is the Qrs complex, there is no P wave preceding it. And then there is another one without any precedent. This is definitely a junctional beat. Now, what is this beat? This beat probably the sinus beat or a retrograde conduction. But the problem with retrograde conduction is most likely retrograde, but you can see there is a P wave here. Probably this patient has marked sinus bradycardia, which is now taken over by the junction at a rate of 28 beats per minute. This patient, unless there is high dose of, as mentioned before, beta blocker, calcium channel blocker, or antiarrhythmic that can cause bradycardia, will need a permanent pacemaker implantation. So this is another patient. This patient again came with history of syncope, but the first ECG, anybody wants to do this one?
কেউ হ্যান্ড রাইজ করেন দেখি, না হলে কিন্তু কারো উপর চাপিয়ে দেওয়া হবে। ডক্টর সাইফ, হ্যাঁ Dr. Saifullah Rajin.
Yes, sir.
Yes, good,
Okay.
good morning. So
Good
the
morning, sir.
heart rate is 119. What do you think of this ECG?
So heart rate is 190 and rhythm is irregular.
Mhm.
And, rhythm is irregular and the sinus.
Is it sinus?
2, 3.
Well, if
Sir,
it is irregularly irregular, right?
regularly irregular. Yes, sir.
Yes. If it is irregularly irregular, which rhythm can it be?
Atrial fibrillation, sir.
Yes. And look at this. Where my pointer is,
Yes,
there is
sir.
a little bit of slow heart rate, but there is no P wave here. So this is atrial fibrillation, right?
Yes,
And
sir.
what is the QRS? Is narrow or wide?
Qrs, sir, wide, sir.
Wide. Why is it wide? What kind of bundle branch is this? Right or left?
Right.
Sir, right bundle block.
Yes. If you look at lead V1, M pattern, RSR pattern. So this is right bundle branch. So atrial fibrillation with rapid ventricular response. So look at this ECG. This was March 1st, 2018 at 9:02. Patient with syncope, and then the patient converts after about an hour. This converts to totally asystole. There is a one P wave with a QRS complex, and then there's a long pause, about 25-30 seconds before converting back. So this patient this finding is consistent with 6 sinus syndrome. And so in a patient with history of syncope, this patient will need a permanent pacemaker, but to prevent any further syncope, I will probably immediately put a temporary pacemaker in, and then decide on to put permanent pacemaker. And this is the patient later on. The rhythm comes back with it's an ectopic atrial rhythm because it's a lead V1 P wave is upright only, and it's kind of funny looking biphasic P wave in 2-3 AVF. So it's an ectopic atrial rhythm with history of this pause and sinus atrial fibrillation. There's another patient. It's a 68-year-old female with history of dizziness. And as you can see that this patient, what the patient has is, if I start with this beat, there is a P wave. For it to if you block, there is a QRS complex. And then there is nothing, followed by junctional beat. And then there is a P wave for a degree heavy block. So this is basically marked sinus bradycardia with junctional escape beat. And in a patient, 68-year-old female with a disease spell, this is consistent with 6 sinus syndrome. There is some ST segment changes where I'm not touching those today, and I'll comment it as possible ischemia. Or sometimes it can be also from digital, because it's a sagging ST segment depression. So this finding again is consistent with 6 sinus syndrome, and this patient should be admitted to hospital. And if there is any medication that can cause this bradycardia, that should be held, and then make a decision whether this patient is a permanent pacemaker or not.
It's regularly irregular, sir.
Yes.
No,
Yeah,
no.
yes, no, you're right. Regularly irregular, because you see there is junction beat, a sinus beat. Junction beat, sinus beat. So clearly, yes, regularly irregular. But there is a pattern, there's a pattern of bigemini pattern. So this is consistent with 6 sinus syndrome. So this is another patient. Anybody wants to do this one? Nobody?
Dr. Saidul Rahman.
Navin
Okay.
Shah.
Okay.
Navin Shah.
Navin Shah.
Yes, Navin, what do you think? Sam?
Sir, this patient heart rate is 39 and
Yes.
rhythm is irregular and
Okay.
show multiple P wave seen in rhythm history.
So what do you think is the diagnosis?
My probable diagnosis is atrial
Fibrillation. Okay.
Sorry, sir.
Yes. So
Yes.
but you said there is P wave, right?
G. Yes.
Where? Which lead?
In lead 2, there is
Lead 2. It looks like, but if you look at lead 2 in the beginning, it looks like a P wave, but follow it. Do you see anything near my arrow?
no, but
Look at this AVL, there is nothing, right? In AVR, there is this funny line. So this is very much consistent with atrial fibrillation.
yes.
And there is bradycardia, right? And
And
what is the
bradycardia.
Qrs complex like? What do you think of the Qrs complex?
Qrs complex is long.
Right.
This
Wide. And why is it wide?
RBBB.
due to right bundle
bundle
branch block,
Right bundle, and also patient has left axis deviation,
left axis deviation. So
bifascicular block. So
Bifascicular
atrial
block.
fibrillation with marked bradycardia with bifascicular block. But this patient is on beta blocker, on labetalol 200 milligrams BID. So that's a pretty big dose of labetalol. So one thing that we did, we held the medicine and May 13, please, Nobin, please stay with me. Next day, this is the ECG of the same patient next day. Heart rate now is 148. What do you think of this?
here clearly seen in PF in lead 2 before
Okay.
is QRS,
Yes.
and
PR interval?
bundle branch is
No,
block
what
is
is the PR
present.
interval?
PR interval is long,
Long.
Long.
It's
more
about
than
270 milliseconds.
270.
Right.
Yes. And if it is the same patient, so right bundle, left anterior fascicular block. So what is your diagnosis?
First degree AB block.
Trifascicular block.
Sinus bradycardia with first degree. Anybody else have any comment on this?
Trifascicular block, sir.
Trifascicular block.
Trifascicular block, sir.
Trifascicular block.
Okay, fine. So sinus bradycardia with trifascicular block. Anybody else want to add anything more?
Nobin Shah. Where is Nobin Shah?
G. I am here.
Yes. Anybody else?
Are কোনো
So-
comment? Okay, anybody else? Mahmudul Hasan?
Sir, long QTCs are prolonged.
QT interval, if you look at from here to here, it's about 500 milliseconds. But please remember one thing. When you have bundle branch block,
Sir, voltage get at LVAs.
okay, so let me look at something else. This, what you have diagnosed is correct, but something looks funny. This P wave,
Is biphasic.
now look at this P wave. What is this? What is this?
Inverted.
Okay, let's go
Maybe
down.
T-
Yeah, go ahead. Maybe.
Maybe
Twist
T
one
wave.
block, sir.
Yes.
Twist
Remember
one
that.
block, sir.
Sorry,
Yes.
2:1 block.
2 to 1 block, sir.
This is a yes. This is a very, very common mistake, and even the cardiologist will miss this. So when somebody has first degree AV block, right bundle, left anterior fascicular block, sinus, what do you think sinus bradycardia? Always look for another P wave. And if you look at lead 2, can you see my arrow? You can
G.
see
Yes.
maybe there is a P wave here. Now you can say, well, how do you notice P? Maybe a T wave. So let's look at this ECG, same patient, next day. Now you can see the P wave better, right?
Yes.
Yes, sir.
One.
Now see
Yes.
both peer.
Yes.
are
So this is very important. Why it is important? Look, this patient with syncope, even without syncope, and then if I miss this 2-to-1 heart block, the patient can have syncope at home or while driving. So this is what you reported initially: sinus bradycardia, right bundle branch block, left anterior fascicular block. Perfectly correct. Anytime you see this similar ECG, always try to find out if there is a second P wave. And sometimes you may need additional EKG or rhythm strip to find out. like this patient next day, as the rate slowed down a little bit, I could see the P wave much more clearly. So now this is the patient came on the 28th of April, 28th of July, May. Just one second, March. I'm sorry, I made a mistake. This is the older ECG. It is March actually, not May. March 30 patient came, and then 31st, and then 1st of April, still bradycardic despite holding medicine. So with 2-to-1 heart block. And then definitely this patient will need pacemaker. Please remember one thing. It is very unlikely for beta blocker to cause heart block, because if I give somebody large dose of beta blocker, it will first cause sinus bradycardia before causing heart block. This patient does not have sinus bradycardia because this patient's sinus rate is around 78 beats per minute. So this doesn't have sinus bradycardia. So beta blocker is unlikely to cause heart block. It can cause sinus bradycardia, not heart block.
Yes.
This is another patient with syncope. So similar thing. Again, this is a little bit easier to see because the rate is lower. As you can see, there is a P wave followed by Qrs. It's a little bit faded ECG, and then there is a P wave, another one. You can confuse this P wave as E wave because it just comes after the T wave. But this is, again, sinus rhythm with 2-to-1 heart block, right bundle bunch block. And so this patient, again, is somebody that has to be dealt with, should be in the hospital, and will probably end up needing a permanent pacemaker. Anybody wants to do this one?
স্যার একটা কোশ্চেন আছে, কোশ্চেনটা নিয়ে নিব স্যার?
Yes, of course.
Dr. Arfa Rahman Ava, sir,
Yes.
if there is sinus bradycardia, if any receive beta blockers, then
Yes.
we will advise for withdraw the drug. What is the actual time required sinus bradycardia improvement in ECG after withdrawal of drug?
Okay, so this is the golden rule is any drug, if you hold it for 5 half-life, it will disappear from the system. So if I'm giving metoprolol 50 milligrams BID, then after the 5 dose, that means after 2.5 days, it should be totally out, almost out of the system. Please remember this rule for any medicine. Any medicine, if you hold for 5 half-life, it will be washed out from the system, except amiodarone. Amiodarone has a very long half-life of 26 days. So amiodarone takes really few months to wash out from the system.
Okay, Dr. Kamal Parvez, please proceed.
Assalamu alaikum, sir. This ECG showed there is 2:1 AV block with right bundle branch morphology with
And left
bradycardia,
left
atrial
left anterior
fascicular.
hemiblock.
Okay, so that's fantastic. This is great. So again, if you suddenly look at it, like if you look at lead V1, a lot of times you will have a tendency to miss the second P wave, and it can be reported as sinus bradycardia with normal PR interval, right bundle, left anterior fascicular block. But carefully look for a second P wave, and you will find that. Because also it becomes more confusing if the rate was a little faster. If the rate was a little faster, P wave gets on the T wave, you will not be able to see it. But, thank you, this is good. Again, this patient should be admitted to hospital. You can hold the medications, but medication does not cause this one. This patient is a 70-year-old male with history. This patient actually did not have syncope. His problem was exertional shortness of breath. And the reason he was getting short of breath, that because of 2-to-1 heart block, when he exercised, his heart rate did not increase enough. So that was his symptom. So you can see this P waves. So 2-to-1 conduction. So 2-to-1 heart block with right bundle. Somebody wants to do this one?
Sir, একটা question নিয়ে নিবে, sir. There is a question,
Yes.
sir.
Yes.
Sir, how to from Mahmudul Hassan?
Yes.
Sir, how to differentiate?
You broke up. Hassan?
Sir, may I ask the question on behalf of Hasan bhai?
Sir.
Yes.
Hello?
Yes.
Sorry.
Okay, Mahmudul Hassan, তুমি directly question করো, সমস্যা নাই.
How to differentiate between P wave, T wave, and U wave in case of
Oh.
confusion? And
Of course.
sir, my another question was, we
No, let's
have
do
to monitor. Yes,
let's
sir.
do one at a time. One at a time. Okay.
Okay, sir. Okay.
So this one, look at this ECG. So I have P wave, QRS, right? Then T wave, and there is a wave here, right? It can be U wave or another P wave. One of the way to differentiate would be if I put a caliper, if I look at the interval, this should be same, but not always true, because look at this, 1, 2, 3, 4 boxes. 1, 2, 3, 4 boxes, little bit longer here. So that's because of little bit of sinus arrhythmia. What you do then, if you are confused in this ECG, look at other leads. Number 1. If you look at lead V1, that doesn't look like E wave. And you can say, well, this is the negative component of E wave. And then do another ECG. If you find that this one dissociates from the T wave, that's the way to differentiate it. But a lot of times it is confused. It can be confused, especially this one. If I gave you this ECG, if you just gave me this without anything else, it will be difficult for me to say whether this is a U wave or P wave. There's no question about it. What is your second question?
In case of patients when we find heart block or bradycardia, we take the history of consuming or assumption of beta blocker or drugs like that. Is there any specific dose or level at which the beta blockers can cause bradycardia? Because there are patients who are taking beta blockers for a long time. Then why
Yes.
suddenly they develop bradycardia?
Yes. So this is a very good question, because unless the patients are on a very big dose, first of all, if the patient come with heart block, it is unlikely that this is due to beta blocker. That's number 1. Number 2, let's say if I take a 60-year-old male and develops sinus bradycardia on a medicine which he has been on for a long time, it is very, very unlikely that this is due to the beta blocker. Or they can become sensitive to beta blocker because of sinus node dysfunction. That probably is the mechanism. Otherwise, a normal dose of beta blocker, I mean, I'm talking about 25 or 50 milligram BID, it is unlikely to cause marked bradycardia. But of course, this can be true for older patients. If I have an 80-year-old male and they can be very, very sensitive to beta blocker because of the age, they have some sinus node dysfunction. But it's a very valid question. Has it answered your question?
Yes, sir. Sir, if you permit, may I ask another question or later?
Sure. No, go ahead.
Sir, we have to measure the drug concentration in some cases, like the digoxin level. And
Yes.
there are also some other drugs like lithium or etc. etc.
Yes.
Sir, what are the drugs we need to monitor the drug concentration while treating the patient or while in emergency basis?
Well, the question is, do we need to check the drug level? Drug level, we don't measure drug level of all medicines. Like beta blocker, I don't remember that if we ever measured it. The reason you measure digoxin is the therapeutic window, because digoxin has a very narrow therapeutic window. So beyond that, it develops toxicity. The drugs that have narrow therapeutic window, you have to check drug level. You do drug level for antibiotics. Like if you are giving vancomycin with somebody with renal impairment, you may have to check the level. But beta blockers, calcium channel blocker, ACE inhibitors, we don't check any blood level because they have a very wide therapeutic window. Okay. All right.
All right, sir. So last question, sir.
Yes.
Does quetiapine causes tachycardia or any cardiac abnormality, or is it safe in case of cardiac patient?
I couldn't hear the question. Can you repeat it?
Sir,
There is somebody else. Can you can you make other people mute?
Online. Free.
sir, can you,
Yes, go ahead.
sir, does quetiapine or antipsychotic drugs, which we commonly use, causes tachycardia, or are they safe in case of cardiac patient, or are
What
there
is the drug name?
Sir, quetiapine, sir. Quetiapine. Quite.
What
Tablet
is the
quite.
no? But what is the generic name?
Sir, generic name is quetiapine.
Oh, I don't
Quetiapine.
know. No, I don't know. Actually, you have to look it up. I'm not used to this medicine. So if you look into there are a lot of antipsychotic medications can cause ECG abnormality, especially some of them can cause QT prolongation, QRS widening. So you have to look at individual drugs. And some of them do require monitoring by ECG monitoring. A lot of the antipsychotic drugs that you have to do periodic QT interval monitoring, QRS duration monitoring, and all of them are labeled with the drug.
Thank you, sir. But my question is gross question is that, are they very harmful that they can cause sudden cardiac death or sudden severe emergency?
Yes, it is true, because there are some antipsychotic medication can cause prolongation of QT interval. Unfortunately, drug-induced prolongation of QT interval, you cannot predict it. So that's why you need to measure the QT interval, because what can happen, actually, it can cause sudden death. If the QT prolongs, they can develop torsade and die from that. It is rare, but it can happen. And that is the reason that a lot of this antipsychotic medication, that it is recommended that they should get, after several doses, they should get ECG to look at the QT interval. I think this is an important point to make, and especially with antipsychotic medications.
The QT prolongation, what you have already told, sir. What are those drugs, sir, which can cause QT prolongation and sudden cardiac?
There are hundreds of drugs that can cause QT prolongation. But antipsychotic drugs, any antipsychotic, when you use, you just look it up. Does it cause QT prolongation? You know, there's one thing that we don't do anymore. Is there was a time we used to memorize things. So you have to go to an exam and you say, look, I know 150 causes of QT prolongation. You don't need to do that anymore. What you do, you remember the principle. And so you keep your brain fixed. But if you remember the principle that antipsychotic drugs can prolong QT intervals, then you, every time you start a medicine, you look it up and look into it. What can it do? Or here we have pharmacists. They will actually alert us. They will alert us if there is any drug interaction, because patients are on multiple medicine. So you are starting a medicine, and by itself, it cannot cause much QT prolongation, but you can combine it with another medicine, and both of them can cause significant QT prolongation. Over here, the pharmacist will tell us that, look, you are giving, as a matter of fact, now what happens, when we write prescription, we use computer. And the computer actually immediately will tell me that you are using two drugs, both of which can cause QT prolongation. And if that happens, patient can be dangerous for them. It will not prevent me from writing the prescription, but it will warn me, and it will be my clinical judgment to decide. Or I can say, well, I'm going to start the medicine. I'm going to get another ECG in maybe a few days. All right. So this ECG, who's going to do this? the reason we are doing this, that I'm just going over ECGs, that if we send some of these patients home, it can be dangerous. Sabir, can you tell me about this ECG?
Assalamu alaikum, sir.
Awesome. Heart rate is 39.
Yes, sir. Sinus bradycardia, POA preceding Qrs complex, PR prolonged.
And how
RSR,
prolonged is the PR?
uh,
Complete heart block.
No, let him do that. PR is prolonged
Sir,
here. Can you see my
six-
pointer?
yes,
600
sir.
milliseconds, right?
600 minutes. Yes, sir.
Okay. But look at the one before. It's about 720 milliseconds.
Yes.
So it's a little variable, right?
Yes, sir.
So, okay, fine. So you start with your assumption was sinus rhythm with first degree AV block, right?
Yes, sir. With underlying
Okay.
right bundle branch and left anterior hemiblock.
Okay, fine. So let's follow this. The first one, PR prolonged, 600 millisecond. Second one, 720 millisecond. Third one, 600 millisecond. This one, again 720 millisecond. This is long. This is long. Look at this. This is long, but there is another one.
Yes, sir.
Okay, now let's go backward. So if I go backward now, there is a P wave here. There is a P wave here. Look at this QRS. This is different from this one. So maybe there is a P wave here. So look at this now. So I have marked it. P, P, possible P. There is a P wave. Maybe there is a P wave inside the QRS. I cannot see. There is a P wave. There is a P, another probably inside the QRS. And maybe there is a P wave here. And you see the P wave here?
Yes, sir.
And here. See?
Yes, sir.
So now what is your diagnosis?
Sir, I think here twist to one AB block.
But, okay, your first diagnosis was first degree AV block, right?
Yes.
Now
Sir.
2 to 1. But look at this. There is no relation between P and QRS. You see here?
Yes, sir.
P and
So
QRS, they are totally dissociated.
complete AB dissociation.
Complete heart block.
Yes, sir.
So this is ECG, what you said. If I looked at it suddenly, I'll have a temptation to call it first degree AV block. I mean, somebody can say, well, you cannot that long PR interval. You can actually get very prolonged first degree AV block. It is rare, but you can get. But this one, what it tells you that if I just gave you a little bit of this ECG, it would have clearly looked like 2 to 1 heart block. But if you follow the rhythm stream, you can see the complete heart block. So it is not sinus bradycardia, it's a complete heart block with right bundle and left end. So where is this ventricular rhythm coming from? Anybody? Okay, we'll skip that part question. So this patient, look at this, what happened to this patient. This patient on the 9th, and it was on the telemetry without a temporary pacemaker, and again bradycardic. What's happening here, Sabir?
So developed premature ventricular contraction with compensatory pause and TDP, torsades points.
Yes. So there was, look at the QT interval, long, right?
Prolonged QT.
PVC, QT becomes very long and develops torsade. And this is totally related. This patient, what will you do with this patient?
Magnesium.
So magnesium sulfate
And what else?
and sir,
Isoprene.
cardioversion.
No, torsade,
Isoprene.
I don't, isoprenaline to increase the rate. Will you give this patient amiodarone?
No, sir.
Yes, why not?
Amiodarone cause sir long QT.
Prolonged QT that
Prolonged
maybe
To make it exactly, we should
turn
not
to
use
VF.
we should not use any antiarrhythmic medication for this. So this patient, isoprenaline, we can give magnesium, and the best thing would be we put a temporary pacemaker bit in. as soon as I put a temporary pacemaker in, this patient is going to be fine, and then permanent pacemaker. So that's what we did. Patient got a permanent pacemaker. You see P wave followed by pacing spike and QRS. So atrial sinus ventricular paced rhythm. So this patient did fine. Sabi, you want to do this one?
Sir, here I cannot see any clear P wave.
Okay.
And
Rate is
I think-
32. Is it
I think-
regular or irregular?
sir, I think more or less regular.
Okay. So what is the
I-
underlying?
I think
Junctional
junctional
bradycardia.
bradycardia, sir.
What is it?
Junctional bradycardia, sir.
Okay. Look at lead 2. Look at the baseline. This is not a straight line.
Yes, sir.
What is this? This is fibrillation. So this patient has atrial fibrillation. Looks like. Okay, sorry, I changed the IC. So this patient has, if you look at the lead 2, there is no P wave, and there is the baseline is kind of wavy. So it is underlying atrial fibrillation. So if it is underlying atrial fibrillation, how come the rhythm is regular?
Sir, dioxin toxicity.
Okay, that's possibility. But what is the ECG diagnosis?
Sir, atrial fibrillation with complete heart block.
Exactly. In atrial fibrillation, only time you will see regular RR interval is when they develop complete heart block. Now, if this patient is on digoxin, then I have to hold the digoxin. But if the patient is not on digoxin, then it's basically underlying complete heart block, unless there is some other medicine that is causing it. So, but please remember, patient with atrial fibrillation, if they present with bradycardia with a regular RR interval, that is underlying complete heart block. So no question about that. So another patient, so this is another one, you can see that the QRS is of left bundle morphology, and I can see P wave here, P wave over here, P wave here, P wave here. So, but over here, there is a P wave here, and there is a P wave here. So there's now, there is a P is totally dissociated. So this is again, another patient with complete heart block with escape beat or left bundle morphology.
Sir, এখানে কি স্যার ভেন্ট্রিকুলার পিএসবি ছিল স্যার ভেন্ট্রিকুলার স্পাইক দেখা যাচ্ছে V5 এ
Yes, there is a ventricular pacing spike because this patient already got a temporary pacemaker. So you can see the 2 pacing spike here. The rest of them probably are paced rhythm, you just cannot see the spike. So this is another one. This patient, so if you look at here, it looks sinus rhythm with first degree AV block. Sinus rhythm with first degree AV block. But look here, PR is shorter, and now you can see another P wave. Now, if I go back, I can see more P wave. Look at this. So, if I start a P wave here, maybe a P wave here, because, and then maybe a P wave here. There's a P here. You can see the P wave here. Now, the way I know this is the P wave, if you look at this T wave and this T wave, there's a different shape. And this distortion of the shape was caused by the P wave. So this is total AV dissociation. But again, it's a little confusing ECG. If I saw the beginning part, I was just seeing of sinus bradycardia with first degree AV block. So some of this patient, you need long rhythm strip to confirm if there is the underlying heart block. Again, why this is important? Because this patient should be in the hospital. I mean, we cannot just send this patient home.
স্যার
Can somebody do it?
কোশ্চেন ছিল স্যার
What is it?
স্যার একটা কোশ্চেন ছিল
Yeah, go ahead.
স্যার আমার কোশ্চেনটা স্যার অনেক সময় স্যার মানে কমপ্লিট হার্ট ব্লকের ক্ষেত্রে কি স্যার সবসময় রিদম রেগুলার থাকতে হবে, বা দেখা যাচ্ছে মাঝে মধ্যে যদি ইরেগুলার থাকে তখনও আমরা কমপ্লিট হার্ট ব্লক বলতে পারবো স্যার?
Well, so the question is, If it is complete heart block, 99% of the time it is going to be regular, unless you have some kind of ventricular arrhythmia going on at the same time. So let's say I have this QRS probably the junctional escape, and then I have a PVC that can cause irregularity. It is rare, it can happen. So the main clue to the diagnosis is AV dissociation, is the key to the diagnosis. So who was this? Who asked the question?
Sir, Buddhadev Ganguly, sir.
Acha, what do you think of this? This ECG you will never see, because in our hospital we can pull
Low
up
voltage
quick.
QRS.
Huh?
Low voltage QRS, sir.
Yes.
Low voltage ECG.
But these were not QRS. These are actually P wave only. So for some reason, this patient was in a monitoring unit in ICU, and otherwise it becomes very disturbing for everybody, for the audience and the speaker also. So this is another patient of mine. This is interesting because this patient came to the hospital with syncope, and this is the ECG. You can see that patient is in complete heart block with a heart rate of 15 beats per minute, and later on had normal conduction, but right bundle branch block, left antivesical block. The same patient went to another hospital a few days ago with syncope. And if somebody has conduction system disease, which shows right bundle branch block, left antivesical block, and syncope, it should be, we need to pay attention to those patients. We cannot just send patients home if they have history. Only patient that we can send home from the emergency room with history of syncope will be patient. If I have a young patient, no history of cardiac abnormality, 12-lead ECG is normal if echocardiogram is normal, then those patients are safe to go home. The rest of them should be worked up, like this patient. And so she luckily had a second syncope, but did not have any significant injury or anything, and she was not driving when this happened. If she was driving while this ECG was happening, she would have killed herself by the accident. And this patient has a long QT interval. That QT long prolongation is due to the complete heart block, and the treatment is basically permanent pacemaker implantation. So now we'll talk a little bit about ST segment. That this is the QRS complex, Qrs complex. You can see that QRS complex, and this portion is the ST segment. And we define terms J point, ST segment, and T wave. And this is a normal ECG. You can see that the isoelectric ST segment is isoelectric in all leads. Now, ST segment, what can happen? We can have elevation, depression. We'll talk about elevation today only. And one of the things that you can see that this ECG, all the ST segment is isoelectric except here in lead V2. And if I amplified this, you can see that the ST segment is elevated. But this is a normal finding. Please remember that in lead V1, in V2 and V3, sometimes you can see ST elevation in young people or normal people. This is a normal variant. So if there is transmural ischemia, we can develop, this is subendocardial ischemia, we develop ST depression. And if it is transmural ischemia, then we can develop ST depression, ST elevation. And there are grades of ischemia. So if this is a normal ECG, initial finding that we get is hyperacute T wave. Sometimes this is the time that people will miss acute myocardial infarction. But if you see any hyperacute T wave in a patient with chest pain, you have to pay attention to this ECG. Now, this similar ECG, if the patient is totally pain-free, then you may ignore that, but not in the setting of a chest pain. And then what happens? There is ST segment elevation, initially a little bit concave, and then it becomes convex ST elevation. And there are different types of ST elevation. One is the convex ST elevation. One is, this is convex. This is also convex. You can have a flat plateau ST elevation. And then you can sometimes have concave. Concave is not very typical for ischemia, but if it takes up the Qrs complex, then it is more or less likely due to ischemia. So this is a patient. You can see that there is ST elevation in lead V1, V2, V3, V4, V5, and V6, and lead 1 in AVL. But interesting is that if you can see that these patients have already developed Q waves. So this patient probably presented to hospital a little late. And this ECG finding is consistent with anterolateral myocardial infarction and probably ongoing ischemia in the lateral leads. And this is another patient with this one, you can see that the T wave is becoming prominent, but then this patient also has ST elevation, little bit of ST elevation, but not very marked. If you look at lead V4, you can see that T wave is a little prominent. But if this patient did not have chest pain, we will not probably pay much attention to this ECG at all. The same patient, if we look at the right coronary artery is normal, but you can see this is RAO view, the left anterior descending artery is totally occluded. So this patient had and it stented out. There's another one, patient with sinus tachycardia. You can see that ST elevation in V2, V3, V4, V5, V6 with terminal T inversion, but this anterior lead has already developed Q waves. That means probably the patient presented a little late, so that there is already Q wave development. And again, what we do, we look at location. So if somebody has ST elevation in V1, V2, V3, it will be anterior. If it is V5, V6, and 1 AVL, it will be lateral. If the ST elevation is in 2, 3 AVF, that's inferior myocardial infarction. So that patient had RCA was normal, but this is LAO view. You can see the left anterior descending coronary artery is occluded, and this was the area that showed ST elevation, anterolateral leads. Anybody wants to tell me about this one?
Sir, assalamu alaikum, sir.
Understand?
Sir, heart rate is 103 beat per minute.
Yes.
There is P wave is present.
Yes.
There is a ST elevation in lead 2, 3 AVF, and
Yes.
there is Q wave in V1, 2, 3.
Yes. You see, V1
And
there is a
also-
Q wave. No, just 1 second.
This,
V1 there is Q. In V2, is there a Q wave?
no, sir, no, this is not.
You see, there is, even if there is a tiny R wave, you will not define it as a Q wave.
Okay, sir.
Over here, even V3, there is a tiny R wave. So probably not.
And there is also reciprocal change in lead 1 and AVL.
Yes. So what is the MI?
It's inferior.
Which blood vessel, which vessel do you think is involved?
Probably right, sir.
Yes. So right coronary artery comes from the right side and goes to the inferior surface. So this is the, again, I'm coming back. 2, 3 AVF are inferior. So an inferior surface is right coronary artery, sometimes part of the left coronary artery. So this patient, if you look at the left coronary artery, this is fairly open. There's a little bit of narrowing, but right coronary artery is totally occluded. And after stent placement, it is open up. So clearly, it is right coronary artery inferior MI. Sometimes inferior MI is very difficult to see because in other leads, you will get good ST elevation, but sometimes, like if you look at this one, lead 2, very subtle ST elevation. Of course, in lead 3, you can see it better. And again, this is an acute inferior MI, and there is a Q wave in lead 3 and AVF. So now, what is important? So this is, Hassan asked me to talk about this acute MI. Why is it important to recognize? There is one issue. Recently, I heard that there was a physician. He was working in a peripheral hospital, and he had an acute myocardial infarction. He died from that. Now, the problem in Bangladesh is that Bangladesh actually has developed technology quite a lot compared to what we used to be and compared to similar countries, but it is mainly concentrated in Dhaka. So if you are working in a peripheral hospital, you can take a picture of this ECG and you can send it to a cardiologist in Dhaka. And this is where I think it is important that the physician societies can create a liaison, that a physician from periphery can take a picture and send it to a physician in Dhaka, and just to confirm that is acute MI and what to do about this patient. You cannot just sit doing nothing with this patient. So if we cannot do intervention, which is not possible outside of Dhaka, we can always give streptokinase for these patients. And the treatment-wise, what we do is that we give beta blocker, we give heparin, you relieve pain, and then you can give thrombolytics in a peripheral hospital. Even in America, if we cannot do angioplasty within 90 minutes, we will give thrombolytics. So if there is a hospital which is 90 minutes from the angioplasty center, patient will get thrombolytics. Sometimes it will be given by the paramedics in the ambulance. It can be given. So this is the same patient. Again, subtle ST elevation in the 2-3 AVF inferior myocardial infarction. And again, the culprit vessel was right coronary artery, and after stenting, it is open. This is again, you were talking about reciprocal ST elevation, ST depression. You see, there is massive ST elevation in lead 2-3 AVF and lateral chest lead, and there is ST depression in lead V2 and 3. This reciprocal depression is important for one reason, because sometimes pericarditis ECG can look like acute myocardial infarction, but they will not have reciprocal ST segment change. That is helpful. And again, this patient had right coronary artery occlusion. This is a little tricky ECG. Again, a patient with chest pain. Anybody wants to do this? And what is this?
যার বই লাগবে সে হাত তুলেন, এটা যে পারবে তার জন্য বুক।
So this is a patient, 83-year-old male with chest pain, and this is the ECG.
Okay, Dr. Farhana Tina. Okay.
Yes.
The heart rate is again 103 beat per minute.
Yes.
I think it's irregular, sir. Heart rate, no, sir, irregular not. There is a P wave, and in lead 4, V4, 5, and V6, there is ST depression.
Yes.
And also V1, 2, and there is an ventricular ectopics.
Yes.
Ventricular ectopic.
Sure. So what is your diagnosis?
Sir, this is probably lateral anteroseptal, septal ischemia. Sir, MI probably, sir, subendocardial.
Okay, and somebody else raised hand.
Sir,
can I say I am the
depression in multiple lead, EABR elevated, V1 elevated, so
Sir, LMCS, sir.
Yes, so who was it? Who said that?
Sir, Sabbir.
Sabir. Okay.
Dr.
So
Kothai, do you want to add something?
Yes, sir. I want to say that so there is a ST elevation in the AVR, and there is widespread ST depression
What is
in
ST
many other
depression?
leads. So I think that it's total occlusion.
Yes. Left main disease, sir. I think.
Okay, Sabir said, what Sabir said, so it's interesting because this patient is having chest pain and heart rate is fast, probably because of the chest pain. And there is diffuse ST depression. Remember, ST depression does not tell us anything about the vessel, but one finding that Sabir pointed out, there is ST elevation in lead AVR, and lead V1. And that is, this ECG is not very remarkable ECG, but this finding is very important because this is what happens with left main stenosis. So if you find this, pay attention to it. The same patient, we did an angiogram, right coronary artery very small, but look at the left main. Can you see the left main here? See, tight stenosis. So this is the left main, and this is what view is this? I don't have the view here, but this is probably LAO view, LAD and circumflex. So this is tight left main stenosis. So please remember, I'm going to go back. This ECG is very important, that somebody with chest pain and ST elevation in lead AVR and lead V1, that is suggestive of left main stenosis. And the findings are, you see, widespread horizontal ST depression, most prominent 1 to V4 to V6, that this patient, ST elevation in AVR more than 1 millimeter and ST elevation in AVR more than V1. So these are the findings of left main stenosis. It's very important to identify this patient because this patient can die literally if it is not taken care of immediately. Thank you all.
স্যার এই তিনজনের মাঝে বেস্ট কে ছিল স্যার?
Sabir, got it.
ওকে সাব্বির, আমাকে ইনবক্স করো।
Yes.
Okay, sir. Thank you, sir.
So the other problem that we face is if somebody has left bundle branch block. In left bundle branch block, there is already a ST elevation in lead V1, V2, V3, because that's a normal finding. But if this patient presents with chest pain like this one, has ST elevation, more ST elevation, what is the diagnostic criteria? That ST elevation more 1 millimeter or more concordant with QRS. That means if the QRS is positive and there is more than 1 millimeter ST elevation, that's acute MI. In discordant lead, like here, the QRS is negative, but if the ST elevation is more than 5 millimeter, then it is acute MI. So with left bundle branch block, more than 5 millimeter ST elevation with discordant lead, more than 1 millimeter ST elevation in concordant lead is diagnostic of acute myocardial infarction. It's a little tricky, but please remember this. The only way to remember it, we talked about this, whoever asked me about the medicine, a question that what is the toxicity of this medicine? Just like you cannot remember that, you don't have to. Similarly, this kind of finding, you think about it and they just, this today, when I was a medical student, it was difficult to get information because I had to go to a book, but you can just open your iPhone or any smartphone and you can Google it and you will find the findings. Or what I do, I take picture of this diagnosis and save it in my iPhone so that I can reach it very quickly. So this is another patient. It is sinus rhythm, and you can see there is possible Q wave. So there is a small RS, but in lead V4 there is QS pattern. So this is old anterior myocardial infarction. Same with this patient. There is a small R wave in V1, V2, V3, but V4 there is a Q pattern, but it is kind of changing, and then V5 there is. So it is basically an anterior myocardial infarction, and it is old because there is no acute ST elevation at this time. And there is another one that we have sinus rhythm with a small Q wave. And what is the definition of Q wave? Q wave is more than one box wide and more than 25% of the QRS complex. So this one fulfills the criteria of, so this is wider than one box and deeper than 25% of the QRS complex. So this is the old inferior myocardial infarction. And same with this one. If I expand it, you can see that lead 2, 3 AVF, there is a Q wave. It is the old myocardial infarction. And this per se is not an emergency. If this patient is not having chest pain, it doesn't really matter. This is just an ECG finding that you need to remember. Now there is another ECG, this one. There is diffuse ST elevation. Anybody comment on this one? What is this?
Sir, Assalamualaikum, sir. Can I?
আপনার পরিচয়?
Sir, Mohammad Saifur Rahman.
Okay, please.
Saifur. What do you think?
Sir, there is sir the heart first of the heart rate. The heart rate
Yes.
is around sir
90, 95, 98.
90 to 95. Yes, sir. Then the rhythm is regular,
Yes.
and sir, it is sinus because the
Yes.
P waves are upright
Yes.
and lead to 3 ABF.
Yep.
And we see, sir, sir, diffuse ST, sir, elevation,
Yes.
but with the concavity, sir, upwards.
Yes.
So,
What is your diagnosis?
so my diagnosis is, sir, acute pericarditis. Sir.
Yes. So, but look at this lead V2. It's convex. Now,
That's it, right, sir?
yes. So this kind of ECG can be very confusing because but if somebody had acute myocardial infarction with this much change in all the blood vessels, the patient will be really, really sick. So this is most likely pericarditis. How are you going to differentiate between the two? Except for I have just ECG.
Sir, sir.
Well, MI, if it is a recent MI, there will be no Q wave. But I have this ECG in somebody with chest pain. I think this is pericarditis, but I am also confused because V2 ST segment is convex. What test can I do to differentiate?
Assalamualaikum, sir.
Yes, I have all those findings, but still I am a little confused because of V2.
Sir, troponin, sir.
Okay. Remember, troponin can increase a little bit during pericarditis also.
Dr. Naim Hassan, Dr. Naim Hassan, Dr. Naim Hassan, kothay? Okay, Dr. Naim Hassan, please.
Echocardiogram.
What will you find in echocardiogram?
আর পেরিকার্ডাইটিস হলে ফিভার থাকবে স্যার
Maybe, may or may not. But you said echocardiogram. What will you find in echocardiogram?
The regional wall motion abnormalities.
Absolutely. This is beautiful because if you do an echocardiogram, if there is acute myocardial infarction, in that territory, the muscle will not move as much. In pericarditis, there will be no regional wall motion abnormality. That will be one test to differentiate. Of course, the clinical scenario also that if the patient chest pain changes with body position, and I can hear friction rub, and then I do an echocardiogram and I find that there is no wall motion abnormality, then it helps me with the diagnosis. The reason it is important is that if this patient has acute myocardial infarction, then I don't give heparin, then I can harm the patient. If the patient has pericarditis and I give heparin, I can develop pericardial effusion. So that's very important. So I think the test-wise is troponin, of course. If the troponin is extremely elevated, then most likely to be acute MI. But if it is borderline elevated, then it can still be pericarditis. Echocardiogram will be a good modality. And the other thing we can do will be a stress test. Sorry, not stress. So very rarely we'll do an angiogram. It is very rare. But so look at these findings that what we can see is PR segment depression. So if we draw a line in the TP segment, you'll find this PR depression. And this is the baseline of the same patient. These are the findings: ST elevation, PR depression, except in AVR and V1, and ST depression in AVR and V1. Those are the findings of pericarditis. I think I'm going to stop here. And if there is any question, I'll take it.
Sir, there are many questions, sir. I mean, do ekta nei, sir.
Sure.
Okay, sir. Sir, what is the Dr. Abhar question? What is the best antihypertensive medication in patients with 6 sinus syndrome?
So what is it? No. So what if somebody has sinus node dysfunction? you want to avoid medicine that are going to affect the sinus node. And the medicines are going to be beta blocker that you can hear me, right?
Yes, sir.
Beta blocker, calcium channel blocker are the medicines that can worsen sinus node function. So ACE inhibitor, not all calcium channel blocker are bad. So you can give amlodipine. Amlodipine does not have much effect on the calcium channel blocker. Amlodipine is fine, and other will be ACE inhibitors. Those are the medicine that you should use if there is sinus node dysfunction.
স্যার আরেকটা কোশ্চেন নেই স্যার, সাইনাস পজ এন্ড সাইনাস অ্যারেস্টের মাঝে ডিফারেন্সিয়েট কেমনে করব বা ডিফারেন্সিয়েটিং পয়েন্ট কি?
Okay, sinus pause and sinus arrest, basically these are interchangeably used. The question would be SA block and sinus arrest. So I did not show any ECG today, but if let's say there is somebody has sinus P2P interval of 800 millisecond, and you see a pause which is 1600 millisecond without a P wave, that is 2-to-1 SA block. But if you see a pause which is not multiple of the P2P interval, that's sinus arrest or sinus pause.
স্যার লাস্ট কোশ্চেন স্যার,
Yes.
অনেক কোশ্চেন আছে স্যার আজকে, ইমিডিয়েট ম্যানেজমেন্ট অফ কিউটি প্রলঙ্গেশন।
Oh, immediate. So it's not the question of immediate management of QT, but it should be, let's say somebody has QT interval of 500 millisecond, and they are on a medicine like amiodarone. You don't have to do anything about it. But on the other hand, a patient comes to the hospital with fever, and you start azithromycin, and next day patient develops prolonged QT with torsade. That will be the question now. So what we will do with that patient, first thing, we stop the medicine. Second, we give magnesium intravenously. Third, we will try to increase the heart rate. So those are the things that we should do. And the heart rate, a quick way of increasing heart rate will be, again, give isoprenaline, or you can give dopamine or dobutamine to increase the heart rate. And then if that's not possible, then of course you can put a temporary pacemaker in until the medicine washes off.
Thank you, sir, very much. It was an outstanding presentation today. কিছু ইনকনভিনিয়েন্সের জন্য স্যার, অন বিহাফ অফ বিডি ফিজিশিয়ানস উই আর এক্সট্রিমলি সরি। ইনশাআল্লাহ হোপ স্যার ইট উইল নট গোনা হ্যাপেন এগেইন। আর স্যার আপনি আশা করতেছি স্যার নেক্সট সেশনের পরে আমরা হয়তো স্যার আপনার সঙ্গে যদি আমরা কোনো ট্রেনিং সেশন শুরু করতে পারি, হয়তো আমরা আমাদের 50 জন বা 100 জনের জুম ট্রেনিং সেশন আপনি যে কোনো কিছু, কারণ আমরা চাচ্ছি স্যার আপনি ইসিজি শেষ করার পরেও আপনি স্যার আমাদের সাথে কানেক্টেড থাকেন কোনো না কোনো ভাবে। আর আপনার আশা করি স্যার এরকম কিছু একটা প্ল্যান করবো, আমরা সিলেক্টেড 50 জন বা 100 জন নিয়ে স্যার একটা আপনার সাথে 1-to-1 ট্রেনিং যদি কিছু করা যায় স্যার, আপনি যদি এরকম কিছু প্ল্যান করেন স্যার, দ্যাট উইল বি ফাইন।
অবশ্যই। ওকে, থ্যাংক ইউ ভেরি মাচ। ওকে
স্যার, থ্যাংক ইউ স্যার।